Welcome back to Made to Be Whole. This is Krista Michener, and we're here with part 2 of our conversation with Randy Breton, compounding pharmacist from InfuServe America. And this week, we're going to be diving into the intricacies of methylene blue. Stay tuned.
Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing.
This is Krista Michener. Welcome back to part 2 of our conversation with compounding pharmacist Randy Breton.
Hey guys. So today we're going to be talking about methylene blue. And this one gets interesting. Okay, so we're going to start with the story. The story starts like this. We've been helping to treat Lyme disease for 27 plus years. We know all of the players. A very prominent Lyme disease doctor called me out of the blue, okay, pun intended, for the dapsone protocol. And for those of you who don't know, the dapsone protocol, dapsone is an older drug, just like methylene blue, that was used to treat things like leprosy and tuberculosis back in the day. But the idea is that you were going to go after the persister cells relative to Lyme disease. And some of you at home would know persister cells as the cyst form of Lyme disease. Now, the thing is that as you increase the doses of dapsone, okay, you get a very interesting side effect, which is something called methglobinemia. And all you need to know about methglobinemia is that's the inability of your red blood cells to transport oxygen, which, as you can imagine, is not a great thing. Well, the antidote for that is methylene blue. And it reverses the process of methglobinemia very quickly, okay, which is why it's still used in emergency rooms for a number of different reasons. Now, in emergency rooms, it's used intravenously to treat things like carbon monoxide poisoning and to some extent cyanide poisoning. Now, those things don't happen very often, fortunately, but that's been its use most recently. Now, this call that I received about 8 years ago, again, was to treat the side effect of the increased doses of dapsone. But nobody had used it orally, the methylene blue orally, as a drug since about World War II, okay? And back in World War II, it was used in the Pacific Theater for things like malaria. That's going to be important in a minute. Keep that in mind as we go through this. So now the doses back then, again, these were in healthy young men in the Pacific Theater going to war. The doses back then were very, very high. The doses were somewhere between 600 and 700 milligrams a day. Okay. Wow. We'll just use that as a reference. Well, I didn't know all of this. When this call came in about 8 or 9 years ago, I said, well, hey, doc, this is all great, but I'm going to have to do a little scholarship on this one. I'll call you back. Well, come to find out, I had to do a lot more scholarship than I thought because it's such an old drug. There's not a whole lot of information out there. Well, come to find out, methylene blue, all told, is probably about 120 years old, plus or minus. It was originally put together. It was one of the first synthesized chemicals, if you will, artificially. Before that time, and now we're talking about 1888, 1890, plus or minus, and they had put this together in the textile industry to dye clothes. Okay. If you ever wore blue jeans, it was probably methylene blue that was doing that. Now and that's why methylene blue is also considered kind of like a dye. Okay. But stop right there. Everyone goes, oh, it's a dye. I can't use it. I'm allergic to dyes. Okay. It's not the kind of dye that you think it is. It's not a food dye. It's a thiazine dye. And again, back then they were just using it to stain clothes. Well, come to find out, because it was synthesized basically in a laboratory, it became the basis for other pharmaceutical drugs. Okay. things like phenothiazines and some of the other more older psychotherapeutic drugs all came from methylene blue. Okay. Not to mention, they found out that it was a great tissue stainer. That's important too. Keep that in mind as we move through this. That was used back in the 30s and to this day is still used as something to stain tissues under a microscope to look at things. Now, back then, when they first started using it to stain things, it helped them elucidate and look at nerve cells. It was the thing that basically changed microscopy for nerve cells was methylene blue. This will be important too. Everything I'm saying is important. So just remember as we move through.
Breadcrumbs.
Follow the breadcrumbs. Back to our problem with our challenge, if you will, with Lyme disease. I found out all of this stuff about it, and I still didn't find anything specifically about the dosing because everyone knew all the dosing for intravenous use, but there was no dosing for oral use. Well, come to find out about 45 years ago, somebody had used it to treat urinary tract infections because it has its own properties. It has antibacterial and antiviral properties all on its own. Okay. And they had used it as a urinary tract disinfectant, if you will. And the doses back then for that were 100 milligrams twice a day. So we cut that in half. So the dose that I called back the doctor with, I said, hey, let's do 50 milligrams twice a day and see what we get. Well, it was a good educated guess. And again, this is for the double dapsone therapy, not for the quad dose, just so everyone's aware. Well, it was a good educated guess because it worked. Okay. Along with other things that you do for that dapsone therapy, it kept the methglobinemia under some sort of control so that they could use the higher doses and go after the persister cells. Well, a funny thing happened on the way to the forum. When we started using the methylene blue in these patients, their Bartonella symptoms got better, like a lot better. Okay. So now I got a whole bunch of doctors that are using it for the dapsone protocol. And now I've got a whole bunch of people that are using it for Bartonella. So, this has continued. There are other uses for it because it has many other different mechanisms of action. Okay, it works great for methglobinemia, but also, again, it has its own antibacterial and antiviral properties. Hence, its worth in treating things like BART. Well, remember I told you, like in the original use of this stuff in World War II, it was used for malaria. Well, malaria and another very common co-infection for Lyme disease patients is babesiosis. Babesiosis and malaria are kissing cousins. So this may be a twofer or a threefer relative to treatment. It is also known, methylene blue is also known as a mechanism of action to help with certain dysregulation or helps regulate better mitochondria. Okay. And and you can't make this stuff up. It's in the literature.
Right.
Do the reading, you're going to find this. That's one of the other kind of mechanisms of action that I think helps Lyme disease patients. And you don't need super high doses of it to do that work. In those types of situations, the dose tends to go down. You tend to do 10 milligrams twice a day, 20 milligrams twice a day. You don't necessarily need the higher doses. And speaking of higher doses, and this is important, because we were doing like 50 milligrams twice a day was working great for the double dapsone therapy. Now, when they started going to quad dose dapsone therapy, a much higher dose, they increased the amount of methylene blue, more towards the area of probably 300 milligrams twice a day, which again, if you were paying attention 5 minutes ago, is about the same type of dose that they were using for anti-malarial properties in World War II. Now, there are at higher doses, you're going to see some of the side effects or some of the interactions that you typically read about online. And this is we need to talk about this area because it's one of the things that kind of prevents people sometimes from using it.
A lot of
They'll
fear
get
and
online.
miseducation about this possible serotonin
There's
syndrome.
a lot. And again, a lot of the a lot of the myth surrounding this has to do with the fact that there isn't a whole lot of information out there to begin with. And the stuff that we have sometimes is misinterpreted. Okay.
And based on those IV doses.
And again, yes,
that...
based on IV doses and not based on oral doses. What I can tell you is, so for everyone playing at home, the issue sometimes is if you go to the internet and you read about methylene blue, you come into this area where it interacts with a whole bunch of other drugs to produce the dreaded serotonin storm. Okay. And this is all based on the fact that methylene blue is a mild, and that's an important word, and dose-related monoamine oxidase inhibitor. Okay. Now, monoamine oxidase inhibitors were put together by Big Pharma sometime back in the 70s-ish area to treat depression. And they were very good at it. Okay. But remember, the monoamine oxidase inhibitors that Big Pharma put together and the mild effect, dose-related effect from methylene blue are not the same thing. Okay. And a lot of that gets conflated because when you read about this online, they didn't really do the work. They didn't really do the research fully. Okay. What they did is they cut and pasted the stuff out of the MAOIs and they pasted it straight into the bucket full for methylene blue, at least using it orally. Okay. And that doesn't necessarily fit the facts. Now, the one thing that we were able to find in medical literature did have to do with IV use. But what it said is that if you kept the dose of the methylene blue under about 5 milligrams per kilogram, which for most human beings is about 300 to 400 milligrams a day, you really didn't see any of the drug interactions. And that fits the facts as we know it, because we've, over the past 8 or 9 years, we've probably dispensed this about 17,000 times at the lower doses. Okay. And we typically do not see the dreaded serotonin storm issue. And again, a lot of that is based on people's experience with the actual MAOI inhibitors back in the day. Everyone usually gets concerned about the use of SSRIs and SNRIs in particular relative to methylene blue. But again, as long as it has mostly to do with the dose of the methylene blue and not with the doses of the other SSRIs or SNRIs that the person might be taking. And again, it fits the facts because the lower doses of methylene blue orally that we use, we didn't really see any interactions with those other items. Now, there's a caveat to that. As the dose goes higher, let's say you're going to do quad dose dapsone, for example, and you're going to have to use 300 milligrams twice a day. Okay. There's two things to remember. Yeah, you're probably going to want to get in touch with the other practitioner and see about tapering off some of the other drugs that have the potential interaction. Because at those higher doses, there is the potential for that. There's one other thing about the higher doses of methylene blue that a practitioner should keep in mind as well. If you're up towards 600 milligrams a day, you can get almost like an idiosyncratic reaction where you're using the methylene blue to treat methglobinemia, right? But if the dose of methylene blue gets too high, you can actually cause the methglobinemia. And again, this doesn't happen with the typical doses that we're using it at. It's 600 milligrams or above, what you're really talking about. And again, you don't really need to be using those doses that high. There's no real need for it, except in certain circumstances.
I was just going to say, and even on that quad dose phase of the dapsone protocol, that's for less than a week. So
right, you're only going to be, doing this for a very short period of time. Yes. Yes.
So tell us, that's obviously why methylene blue at these lower doses can also be great for some people for anxiety, depression, Alzheimer's, I'm assuming because of that mild MAO inhibitor action, which I always think it's funny because I can imagine some people that alarms, because if you think of how many commercials and ads you've seen over the years, my husband, I remember him saying, so basically, if you're taking an MAO inhibitor, you can't take any meds or eat any food because it interacts with everything.
Right. Yeah. Thank you for bringing up the food portion too, because again, this was when I was taught this back when dinosaurs roamed the earth. This was called the wine and cheese effect. Okay. And you can still find references to it, but what it was is that when these and I'm talking specifically about the MAOIs that Big Pharma put out.
The prescription,
okay? The prescription versions of MAOI inhibitors. When these first came out, they did a great job. They were wonderful. They were great at treating depression. But what would happen is that because they were so good at their job, there's also a little tiny side effect with food that has to do with tyramine. Okay, high tyramine containing foods will help you produce more serotonin. Okay. Now, if you're already on something that increases the amount of serotonin, you can, again, push yourself into this serotonin storm area where things start to go a lot faster in your body. Okay. So what was happening is that these people were on these MAOIs. They would go to a party. Okay. And they would eat foods that they would eat quantities of foods and certain foods that they would not normally eat. Okay. Excessive amounts of wine, hard cheeses, beer, things like that, high tyramine containing foods. And they would end up in the emergency room with serotonin storm. And this was always, part of the lore, if you will. And these were things that pharmacists would speak to people about if they were on MAOIs as part of the counseling. So they would know to not avoid it, but be mindful of it. Right. But again, they took that whole pile of information and they just cut it out and they pasted it into the bucket of the methylene blue without taking into account dose
context
context, basically. Yes. Now, the interesting part is that we had two instances where a person ended up with not serotonin storm, but like the pretext to it. And a lot of people have say, okay, well, if this is going to happen, what's it going to look like? Well, the difficulty is that some of the things I'm about to describe are things that people with Lyme disease experience every day. Okay. Right. So it's insomnia, okay, high heart rate, and profuse sweating. But what I tell people is that this has to happen all at the same time. Right. And it's not going to be a secret. You're going to know what's going on. You know your own body. It's going to be pretty obvious.
Pretty sudden onset.
And that's right.
Difficult distinguishing if you're having die-off. I mean, I do see less die-off with methylene blue, but it does happen for some people.
It does.
So,
and we've been having that. Right, because it's effective. Just so everyone's aware, a Herxheimer reaction was something that was basically elucidated by Dr. Herxheimer, okay, back when penicillins were first being introduced, the first antibiotic, right? So what would happen is you would give somebody penicillin, this die-off would occur, and they would get a mild fever and a feeling of malaise, okay? And, he described this, and this became our watchword for other things that happen with Lyme disease folks. Well, it's not exactly just a mild fever and malaise with Lyme disease folks. I wish we had a different word for it, but typically people will use die-off or, Herxheimer reaction. Well, it's not just that. It tends to make all of the symptoms worse. Yes. And what I usually tell people is that I don't want you to feel bad, but it usually means it's working.
Interesting. My oldest son, I started him on just the 10 milligrams of methylene blue because his symptoms are so severe. Just up to 10 once a day. The first week or so, a lot of really severe neurological die-offs. I'm like, okay, it's working. It's working. Mm-hmm. But even the next week, he said, in some ways I feel worse, but in so many ways I'm happier about it. He just said, I'm calmer. Yeah. I can think better. He was already experiencing some of the benefits. And I do try to work people on reframing and saying, okay, if you didn't have this infection and it would not cause this symptom, this is not a side effect. This is because we're actually targeting something effectively. So of course you want to do dosing and you would be nuanced about it and not overwhelm people. But the fact that methylene blue can get to the nervous system, get to the brain so much more effectively than a lot of our other treatments makes it really a very potentially valuable intervention. But why then should people have someone prescribe it for them from a compounding pharmacy instead of going on Amazon and getting a dropper?
Well,
bottle?
that is an excellent, excellent question. And I'll start by a little anecdote. Okay. And this is a lot of people will call me and they'll say, well, oh, Randy, how do you know that the methylene blue that you have is the best version? I said, well, it's because it's $17,000 a kilo. Okay. And
Price is an indicator.
In this case, it does matter. And here's why. And I'm just using that to preface this. Methylene blue, as you can probably tell by the conversation, is a very old drug. Okay. It's used to stain clothes. It's used for a whole bunch of other different things too. Okay. It's used in analytical chemistry. It's used sometimes to clean fish tanks. Okay. Believe it or not, sometimes, and only our men will know this, blue pucks that you see in the bottom of urinals, often that is methylene blue as well.
Interesting.
Okay. Now, there are different grades of methylene blue. Okay. The methylene blue that you're using to clean your fish tank that you order off Amazon is not the same methylene blue that you should be putting into your body. Okay. Because the stuff that you're putting into your fish tank is not controlled in any way. The people that are selling it don't have a license to lose. They don't have any of that stuff. And they don't have to follow the rules that we do. So, I mean, we have to have a certificate of analysis. It has to be methylene blue USP. Okay. It has to, and that's a clearly defined monograph for human use through.
So that means
the
pharmaceutical grade,
pharmaceutical
impurities, suitable for human use.
Yeah, suitable for human use. So the important part is that the best thing to remember about this is that you're already, as a Lyme disease patient or anybody that's taking this kind of thing, you're already in a bad spot. Okay.
Right.
You don't want to make it worse by taking something that has something in it that your body's not going to be able to process. Okay.
Well, aren't some of the impurities potentially, if it's not pharmaceutical grade, like heavy metals and other things like that?
Yeah. Now, here's the thing is about that. Yes. Yeah. And now methylene blue, by its nature, how it's made, there's a certain parts per million of certain types of heavy metals. Those are limited because of its use in humans. Mm-hmm. I mean, it's very, very, and again, parts per million. It's tiny, tiny, tiny. Okay. The stuff that you get off the internet is not. It has much more of these things in it. And again, specifically for my Lyme disease patients, they don't process heavy metals very well anyway. Okay. So you don't want to add fuel to the fire. The other thing about the online stuff is that, yeah, typically it is some sort of liquid, which we've done it before under certain circumstances, but it stains everything. Methylene blue stains everything. And we have some data to support the fact that it may stain teeth or dental work. Okay, which is why we typically
it's a dye. Yeah,
it's a very good.
That's why
dye.
your pee will be blue.
Your pee will be blue. All right, it will be blue. A little tiny caveat to that, which is very interesting, is that when you take methylene blue orally or IV or anyway, when it first gets metabolized, it gets metabolized into half of it becomes colorless. The metabolite doesn't have a color, which is really, really interesting. But yeah, your urine will be blue. That will happen. But
or as my 16-year-old was overheard telling his friends, the most beautiful shade of turquoise you've ever seen.
Yes. Yeah. And the other thing is that depending on what other medications you may be on, that we've noticed, and this is incredibly rare. This happened probably 2 or 3 weeks ago. We had a person who was peeing green. Okay.
Vitamins?
And they were concerned. But come to find out, it was a chemical interaction between the methylene blue and another drug that they were taking.
Oh, Oh,
So
interesting.
you can get different colors.
Sure.
Is the
It's
point.
a science experiment.
Right. It's just a little science experiment. Okay. But
Yeah.
for a good reason. It will stain things. That's why we typically stay away from liquids. In certain circumstances, there's two circumstances where we've kind of gotten away from that. One is we had a person that had a tumor on the side of their tongue. Okay. And where we're utilizing troches, which is just a fancy name for a lifesaver, that had methylene blue in it. So we were intentionally staining the inside of the mouth in that particular area because there's papers on this, certain properties to it for that kind of treatment. Typically last ditch type of treatment. The next one I'm going to talk about is like that. There's such thing as what they call fulminating stage 4 breast cancer. That's where the cancer kind of gets outside of the skin. So we created a topical preparation of methylene blue. And again, this is not for normal use. This would be for situations where you've basically tried everything else. Okay.
So as far as potential contraindications, we do a G6PD level on people before they take methylene blue, which if you're ordering off of Amazon, that's not required.
Right.
But other than not having a normal G6PD level, are there other people that should steer away from methylene blue that you can think of?
Well, that's one of them, but as you're well aware, that's incredibly rare.
Yeah, so rare.
I like the idea that everyone's doing it because it's never a problem until it's a problem. So you want to make sure that that's one less thing to worry about. The only other time that we've really seen any particular problems has to do with the higher doses. And again, that's rare too. So when you're getting into 600 milligrams a day, then yeah, you have to be more cognizant as to what's going on. But for the lower doses, the most you're really going to experience is multicolored urine.
And I just found, starting dose, you can speak to this. If I've got someone who's, I don't know, big tough guy, just depending on what their symptoms are, I have no problem starting them at 25, sometimes at 50. If somebody is more sensitive, a lot of times I'll start at 10 just to be careful. I've had a few people, because they're so exquisitely sensitive, I've started at like 1 and they just kind of respond to everything, but they've been able to work up and get benefits from it. Do you have guidelines?
Of course. This comes down to the kind of the dosing guidelines, if you will. There's two things we have the most experience with. One is the 50 milligrams twice a day. We have a lot of very positive, it's all anecdotal. If you're looking for a double-blind placebo-controlled study, that's not going to happen. The drug's too old. But for the most part, especially in my, Bartonella, Lyme disease type patients, 50 milligrams twice a day doesn't seem to pose any particular problem. However, we have titrated and again, this goes back to your clinical experience with the patient. The labs and the other stuff is not the territory. The territory is your time and the history that you gleaned from the patient asking all the right questions. So that for, Lyme disease, Bartonella, that seems to be a great, kind of starting point. 25 twice a day, 50 twice a day. Now, if you're going more towards the mitochondrial stuff and other stuff, the dose doesn't even need to be that high. You're talking about 10 milligrams twice a day. So that would be how you would start on that side. For the Lyme disease stuff, like I said, 50 twice a day is a starting point. We have, on many occasions, gone with a lower dose once a day for a while to see how the patient reacts. There's no reason to not do that.
This is just my thought, but I always look at what are their symptoms? So what type of die-off could we be experiencing? So if they mostly have musculoskeletal pain and their die-off would include some increased pain, most people are okay with that. But if there's a lot of neuropsychiatric involvement, which can be really distressing, those are the ones I tend to start a little lower because they just get overwhelmed. And they're the ones who tend to be afraid anyways. They're afraid to dip their toes and try new things.
And this is how you do it, because you know your patients. But again, the three kind of entries are, like I said, for mitochondrial stuff, about 10 milligrams twice a day. For BART and Lyme related stuff, like 50 to 100 twice a day. For more sophisticated double dapsone or resistant babesiosis, you're talking about moving more towards 300 twice a day.
And
Okay, so you got kind of three little buckets.
Do you see anecdotally much impact on babesiosis before you get to those higher doses, or is it more?
It's hard to tell because they're already on so many other things.
Overlap, right? Okay.
Yeah, there's so much overlap. Not to get too far off the subject, but we've had recently a lot of good luck as far as babesiosis, utilizing a malaria drug called tafenoquine. And now getting back to the methylene blue and another common co-infection, Bartonella, I can tell you that we've had a lot of good luck with that, and you don't need to push the doses all that high on the methylene blue to get good results. And now for Bart, you will see different antibiotics. So you're going to see doxycycline, azithromycin, and some other stuff.
Bactrim.
Rifampin, Bactrim, things like that. Now, if you, for whatever reason, if you add the methylene blue to your already established protocol for Bartonella, they get better, faster, and stay that way for a longer period of time.
And now, I think too, with so much anxiety being common with Bartonellosis, having that added benefit of something that can be offsetting some of this storm, besides what it's doing as an antimicrobial basis, but just those symptoms.
Yeah, and the other thing that this is anecdotal. It's our suspicion that not only does it have its own antimicrobial properties, but remember when I told you it was a great tissue stainer? Okay. For nerves and things like that. I think it gets through biofilms pretty easily too.
Interesting.
And because of that, I think it carries some of those other antibiotics on its back. And when it gets there, it deposits them. That's why you will sometimes, not always, but a lot of the time, you will see a greater response to the other treatments that you're utilizing, especially as far as BART is concerned.
It's like leveling up on my son's video games, right?
Sometimes, it's like turning up the volume on the antibiotics that you're currently using.
Well, and that's helpful because I do think, again, as you mentioned, a lot of patients with these vector-borne infections have brain fog. Bartonella, I see, cause so much anxiety and inflammation, just people understanding you're not going to take methylene blue and it's going to go all the way, or take this antibiotic or this herbal protocol. It's stacking your gains and getting the synergy that you'll actually be on stuff for a shorter amount of time and have better quality of life. But it is a lot. And I know it's a lot to process when your brain's not well, but there's a method to the madness.
Yeah. And the other thing is using different antibiotics and so forth and so on is sometimes considered, polypharmacy, or excessive use of antibiotics is sometimes put into that wonderful little niche of antibiotic stewardship that everybody loves to bring up all the time. My difficulty with that sometimes is that, again, if we wouldn't be here unless we tried everything else first. Yeah. Okay.
And so, if antibiotics were used appropriately early on, we wouldn't be in this mess either.
We wouldn't be in this situation. Yeah. Correct. And if you go back to, like I said, the original 3 definition version of Lyme disease that I originally said, those are different parts of the cell, and you're going to have to utilize different antibiotics because different antibiotics work on different parts of the cell to do their job. Right. So you're going to have an antibiotic that deals with cell wall. You're going to have an antibiotic that deals with interstitial. You're going to have to try to find antibiotics that work on the cyst form, although that's been difficult for the last 27 years.
Right. Yeah. Well, do you have any parting words of wisdom on methylene blue compounding the universe?
Yeah, here's the thing. Compounding in general, especially for Lyme disease folks, is something that is very useful to practitioners writ large. I wish it was the silver bullet. There's no real silver bullet. But what it does is it enables you to use things in certain ways that you just couldn't do before. It's not just about what it is or how you use it. Sometimes it's about the dosing as well. For the fillers, that's another really good topic. And,
Right.
most people that have Lyme disease, and this is due to the immunological portion, which is very poorly understood, okay, even by the experts relative to Lyme disease. Most Lyme disease patients have some sort of chemical sensitivity, okay, right out of the box, or they'll get sensitive to things that they were never sensitive to before, which is really odd. But this is where compounding comes in. And because we treat so much Lyme disease, we do a lot of this. I mean, I've compounded things in carrot powder because it was the only thing that particular patient could tolerate. Okay. We've done things in coconut powder. We've done things in cassava. And when we compound things, we try to keep the number of excipients, those are the extras, to the lowest portion that we can and still maintain the drug. Okay. Because there's other things that excipients aren't just there as fillers to cause you problems. Okay. Okay. Everyone thinks that because they're allergic to things like titanium dioxide and magnesium stearate and other things. But in some instances, there are reasons for those excipients to be in your preparations. And sometimes this has to do with the degradation of the drugs themselves. Okay. There's a number of different ways this happens. Hydrolysis, UV light, temperature, things like that. This all tends to kind of break drugs down over time. Some of the things that are put in as excipients are to keep that kind of thing from happening. Okay. Some of the other excipients that are put in there are to make the drug a little bit more absorbable. Okay. Because there are certain drugs that if you don't have certain excipients with them, their bioavailability goes to a very small number. And again, same thing happens. If you can't absorb the drug, then you're not getting the benefit. So why are we doing this?
So it's really rewarding to be the superhero who can put something in carrot powder for someone so they can get what they need. That's kind of exciting.
Yes.
I would give you a
little over the
I would give you a cape. No, I would give you a cape.
But yeah, I mean, that's in a nutshell.
At least a letter on your chest, right?
Well, one of the most satisfying parts of this is doing consults like that. And a practitioner will come to us with a problem. Okay, it's like, hey, what do you got? I've had them literally say that to me. It's like, look, this is the difficulty. Is there anything else we could try?
Well, and I want just thanking you from a provider standpoint for not treating us like we're stupid for asking, just.
Oh, no.
Like, sometimes I feel like I'm just this dumb little nurse practitioner, Randy. Help me out. But you're so
the
generous
questions
with your
lead to other
knowledge.
questions. And in certain instances, I've got the answers. In other instances, I don't. And if I don't, sometimes I know the people that do. So,
but what's great, good healthcare should be a team like this. It really should. None of us have all of the pieces of the puzzle. If we had more just open collaboration, that would be great for everyone.
And you're welcome. You're very welcome. Yeah.
Thank you for your knowledge and wisdom and generosity with your time. And remember to have hope because you were made to be whole.
Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.